Hello, everyone. It's Nigel Giam here, the lead GP training program director for St Mary's and course director for Mentor MRCGP. I'm so happy to have Heba here with us to talk about her recent success in the SCA. Congratulations. Really, really happy for you. You must be very, very happy.
Oh, thank you very much, Nigel. Yes, finally, it did.
Finally, I know.
It
It's
did seem,
a struggle. I know. Oh,
yeah, yeah.
and I
Um,
go ahead. Sorry, go ahead. Yes, go ahead.
so I had a first attempt in November, and I didn't pass that, obviously, and then I found out about yourself and your courses, and that's where I realized, I wasn't really prepared for the November exam. I had a different, plan and a different strategy the second time. So I think that's how I made it through in
Yeah.
March. Yeah.
Yeah, and actually that was great. It was a great improvement because, we obviously had you on the course as an observer, and then we did some one-to-one work to look at your battle plans and strategy. So your mark really jumped up 15, 16 marks from 60s into 80s, which is a huge jump. And obviously now that hurdle is over, but unfortunately the hurdle kind of remains for quite a lot of STs out there who, a bit like yourself, when they go into the first sitting, perhaps think they're revising in the right way and then get stung and then have to kind of really rethink their strategies. So I thought it'd be quite useful for our listeners to understand what your game changers were after the
Mm.
first sitting, and then what you did differently for the second sitting,
Mm.
especially after the kind of work that we did as well. So for the data gathering, what did you change to kind of maximize your marks in that domain?
So I changed my approach to asking questions, and in your in your course, there's always an emphasis on the signposting,
Yeah.
trying to tell the patient, trying to involve them, and not only, being there as a hospital, well, I call it a hospital doctor, or
Yeah.
doctor's agenda,
Yes.
and obviously picking up on cues, that was very important.
Yeah.
Um, Trying to be more of a GP than a hospital doctor and not chasing symptoms.
Exactly. Yeah, and actually that's the problem, isn't it? Because I think a lot of study groups will often focus on the clinical skills, the symptom, the diagnosis. We go back into that kind of OSCE mold of just asking questions for the sake of asking questions, and it's not a tick box exercise either. How challenging did you find the kind of priming of the case? Because there's a lot of information for some of these cases that come through in terms of gathering data. What were your approaches to optimizing how you primed the case?
Um, so again, that's another thing I learned in the course. When we had the few cases that you told it, you gave us some time to prime first, and then you asked us questions about how which part of the blueprint do you think this
Yeah.
case is covering?
Yeah.
And then obviously I wasn't doing that when I sat the exam in November. And I realized, yes, because the exam will have to include each part of the blueprint.
Yeah.
So there will be a case of child health. There will be a case of urgent health. There will be a case of mental health. So having an idea of what could be this case of, what it could be covering, it gives you, um, at least some time, maybe
Yeah.
2 minutes even, to plan it and to know what sort of approach you're going to take
Yeah.
for the next 6 minutes or so.
Yeah, I think that's so important, isn't it? Because if you go in blind into the case, not even thinking
Mm,
of the blueprint, then you're going to be chasing your tail for a good 3 or 4 minutes
mm.
before actually recognizing what the priority of the case is. Okay, so we talked about data gathering. What about clinical management? How did you optimize your marks? What was your battle plan for that
Mm.
domain?
So another big thing that I wasn't really doing at all was readdressing ice.
Yeah.
Readdressing ice. That was a big I know I never did I never did it in the very first sit in the first sitting in November. I always went in with, okay, so here are the options. This is what we're gonna do. Oh yeah, and I remember you wanted that medication. No, you can't have it. Okay,
Yeah.
bye.
Yeah. Okay,
So
so
that was
quite militant then, quite doctor driven. Yeah, absolutely. I mean, that's such an important thing, isn't it? Because actually, ICE only works as a question if we use it in our data gathering so we can readdress it. So we're managing actually the patient and their narrative as opposed to just the symptom and the diagnosis. There's been a lot of talk about negotiations in the SCA. Did you find that tough, or did you have many negotiations that came up?
Yeah, yeah, we had a few ca tough cases actually that I think it threw us through all the people who did it on the same day. Well, we did kind of discuss it within ourselves, and it did throw us, but we managed to pass them. Surprisingly, I thought I wouldn't pass them, but I did because I did use the approach of, okay, so this is obviously well, like using the word dilemma
Yeah,
sometimes.
yeah,
um this is something that we're unable to agree upon, but all I can do is advise you. So if I'm telling that patient, and obviously, respecting their autonomy and their right to choose what's best for them and for their own health,
yeah.
but making sure that we do discuss it, and we openly mention that, this is a dilemma. This is what I think will happen if you don't go through with the plan.
Sure.
And yeah, it's just making it like a normal conversation, like you're
Yeah,
having a
yeah,
conversation. Yeah.
absolutely. You've just got to be open and transparent and make sure that,
Mm.
in order for a patient to make a decision, they're informed about, the possible risks and benefits of whatever decision, that we have to kind of work through. And as you said, it is often a dilemma that's presented in real life also. So that takes
Mm.
us, I suppose, on to the last component, which is relating to others, because I suppose just from the inference of what you were saying, there were probably some patients who weren't necessarily happy with the decision, but yet, you can still pass the case because obviously what you're being tested on is how you work through compromise and finding the middle ground. So, what was your kind of battle plan for that relating to others domain?
So relating to others is what you do throughout the whole case. So from the very beginning, even when you greet the patient, if you've read in the case, or in the information that you've been given before, that this patient has recently had a very bad, sort of a cancer diagnosis or a metastatic diagnosis, don't go in and say like, "Hi, how are you doing?" And be very chirpy and happy. And no, well, you need to give them the feeling that you've read their notes, you know what's going on, so you go in, starting it strongly by saying, I understand, I appreciate you've had this recent diagnosis, and I'm very sorry. And this is something also that you taught me, because with the one-to-one cases that we did together, it's it's definitely something I picked up, and I know I wasn't very good at
Yeah,
from the first sitting. Yeah.
yeah. But
And then going on with an sorry, go ahead.
I was just going to say, but actually, just because we had a couple of sessions together, the improvement actually
Yeah.
between, I think we had about three sessions in the end, but the improvement between
Mm.
the first and the last were like chalk and cheese because suddenly you were just having conversations, you were just acknowledging, empathizing, energizing, rather than just processing. So there was a huge shift in energy that I noticed, and I was I know that I said this before you went into your exam that I was very confident that actually you would get the mark that we were kind of predicting. So that was lovely. Sorry to interrupt you. What were you going to say?
Oh no, no, it's all right. So the very first one-to-one we had was actually, you told me something that I just I made sure that I wanted to fix it, and you said you need to smile.
Yes.
You should, stop having this really serious face, because patients, yes, you are a doctor and you're trying to advise patients and have a plan and all that, but you need to smile. I mean, you're still human. They're human as well. So they need to feel that okay, she's with us on the same page, and she's confident in what she's doing. Smiling also gives you that confidence that, okay, we're in this together. We're gonna make it through.
Yeah, absolutely.
Um,
You know what?
mm,
I love that because actually for me, that kind of positive energy starts through
yeah.
how you smile. And actually, it's smiling with your eyes and then your face and then your heart. And Confucius says 3 smiles a day. That's all the medicine that you need. So, I bet you,
Oh,
I bet you've been smiling a lot since passing. Well, hey,
yes, and I've been telling people to smile a lot as well
good.
in the exam, obviously.
Positive energy is infectious. So you're due to see CP really soon next week. I mean, that's exciting stuff. Um,
Yeah.
what's the plan? What's the plan now? What's on the horizon for you?
Um, um, Well, I'm definitely taking a big break first, a few months off, trying to decide what I'm going to do for, in my GP career. Um, and yeah, just talking to a few people to decide to make that decision because it's not very stable out there after CCTing and
Mm.
yeah, we need another battle plan. Yeah.
I can help you. Keep in touch and don't worry, the world will be your oyster. Thank you so much for your time. I'm sure this interview and those
Thank
listeners
you.
find it very, very inspirational. Take care and do keep in touch, Heba.
No, thank you very much, Nigel. Thank you.